Coming to the stage, you guys, from Partner Solutions, because Black Health Matters. Give it up, please, for Ashton Morgan. Clap louder. He's right there. Make him feel bigger than he is. What up, baby?
Good afternoon, everyone. All right, let's get this energy up. I know there's only a few minutes, a few more hours, and we'll be done. So I want to introduce the next panel, and that's Families Matter, Breast Cancer Awareness. So breast cancer affects more women than any other type of cancer and is the leading cause of cancer-related deaths amongst women. That's not good. African American women have a 31% breast cancer mortality rate, the highest of any US racial or ethnic group. For some real talk about the importance of knowing your family history of breast cancer, let's hear from Dr. Ryland Gore, I hope I pronounced that correctly, a board-certified, fellowship-trained surgeon specializing in breast surgical oncology in Atlanta, Georgia. But joining her is Cara Glover, Medical Director of AstraZeneca. I'd like to introduce these lovely, powerful ladies. Give them a round of applause.
Yes, we're so excited to be here.
It's like church, Cara.
Right.
I'm Dr. Ryland Gore. I'm a breast surgical oncologist based in Atlanta, Georgia. So we are so happy to be here. Thank you to AstraZeneca. Thank you to Black Health Matters for sponsoring this component of the program. So we're going to get started.
Yes, and I'm Cara Glover. I'm a medical director at AstraZeneca, and I'll be helping ask some questions to our wonderful surgeon, Dr. Gore. So before I start asking Dr. Gore some questions, I want to know by hands, how many of us know someone who has breast cancer? A sister, a mother, a grandmother?
Wow.
I mean, just take a look around. It's most of us. And we'll be talking about some of that today. Dr. Gore.
Yes.
How often should we be getting mammograms, and when? And how often should we be self-checking?
So self-check, there are some organizations that say you probably shouldn't self-check. It probably does not make a difference. Well, what I tell my patients, especially my minority patients, you know yourself way better than anybody else does. And so you should know what's going on. You should know how it feels. You should know what's abnormal, whether that's a new mass in the breast or underneath the arm, whether it's a skin change, whether it's nipple discharge. There's no reason why, you should wake up and a few months later something happens and you go to the doctor and you're like, I don't know. I have a lot of patients whose partners and significant others actually find their masses too, which is important. So it's important to know your body, and I'm a big proponent of self-checks. When it comes to mammograms, please listen. I don't want to hear anything about every other year or whenever the mood hits me. We should be getting our mammograms done every single year, starting at 40 years old. I'm going to give you a caveat to that, though. There are some organizations now who recommend that Black women and other minority women, our Hispanic women and our other brown women, we should probably start our mammograms at 35 years of age because of the fact that we're more likely to be diagnosed before the age of 40. And so this is very important. We should get it done every single year. My youngest patient with breast cancer, I diagnosed her at 19 years old. And so this is very serious, and this is a disease that's killing Black women disproportionately. And no, your ultrasound is not an alternative to your mammogram. The mammogram looks at totally different things that we don't see on an ultrasound or an MRI. So if you need an ultrasound, great, but you're going to get it done in addition to your mammogram.
How often, everyone?
Every year.
Did she say every 2 years?
No.
I think she said every year, right?
Every year.
Okay.
Yes.
So you named some really good statistics that we should know. Are there some others that we're not, thinking of or that aren't off the top of the mind? Obviously, everyone raised their hands here saying that they know someone with breast cancer, but how often does that happen?
Very often. So 1 in 8 women will be diagnosed with breast cancer in this country. And so if we just look around the room and go 1, 2, 3, 4, 5, 6, 7, 8, we all know somebody or we've been personally affected by it. 75% of women who get a breast cancer diagnosis do not have a family history. So I have a lot of patients say to me, well, this doesn't even run in my family. Welcome to the club. For most people, it doesn't run in their family. Of that 20 to 25% where they do have a family history, a small component of those cases, 5 to 10%, are due to genetic mutations. You heard the last speaker kind of touch on that a little bit. And so genetic testing, something we're going to talk about a little bit later, is a very important component to your care. When it comes to Black women, we're 40% more likely to die from breast cancer. We're more likely to have the most aggressive forms of breast cancer, specifically triple negative breast cancer. That means when we look at that tumor, it doesn't express the female hormones, estrogen and progesterone, and it doesn't express HER2. And so that means when it comes to treatments, there are less targets available to successfully treat and cure you. Our 5-year survival is much lower, even when we control for age and insurance status and all of those things. And so across the board, Black women and brown women get a double hit. And so it's important that we stay vigilant.
You mentioned some of those familiar risks, or some things to keep in mind. What should you be asking? If you're talking to your patients, what should they be asking their provider, about these familial risks?
So first of all, I was appalled to learn this week that there are some people who go to the doctor where the doctor doesn't even touch them. They don't even ask questions like, tell me about your family history. Let's start there. Know your family history, and this is something that your physician should be asking. Sometimes even if a patient isn't diagnosed with breast cancer or some other cancer, you see their history and it's a mess. Everybody on both sides is affected by some kind of chronic disease or cancer, and so for those patients, these are the ones where you should probably say to yourself, you know what, we should get genetic testing. The issue is that Black and Hispanic women, their physicians are less likely to even ask them about genetic testing or their family history. And so it's important when you walk away today, not just from this talk, but all the talks, make sure you're asking the questions and really advocating for yourself. I tell them, especially with the breast cancer diagnosis, it's important to know that the recommendation is that every single woman, it doesn't matter how old you are, if you're diagnosed with breast cancer, your physician should be asking you and offering genetic testing to see if there's a gene that contributed to that. And it affects not just you, but it affects your children as well, male and female children. And so one thing that we don't talk about, for the men in the room, you can get breast cancer too. I take care of quite a few men in my practice. It doesn't happen as often. Male breast cancer cases are only 1% of breast cancer cases each year, so about 2,700 men will be affected each year. But Black men, those statistics are the same as Black women. You're more likely to be diagnosed at a later stage. You're more likely to have aggressive forms of disease. And so that's important to know, and genetic testing can help pick up on that.
So something that we say all the time is family matters. So again, so many hands went up about who knows someone with breast cancer. How can we as a community help support those around us that may have breast cancer?
Ask the questions. I was unnerved to learn about some extra stuff about my family history in the last month, and I had no idea.
So it's hard to ask, right? Even if you do, you get some roundabout answer. You never get the exact answer. So
the problem, sometimes they don't know. How many times have our grandmothers and other older family members gone to the doctor and somebody just told them, well, go here, or you need this, and there's no explanation. And so I think we need to get back to, for some people, what's important to them is having physicians and surgeons that look like them. And so also, if you don't feel comfortable when you walk into the room, just say, okay, thank you. And then you find somebody else. And it's a lot, and it's taxing, because how many of us know a whole bunch of physicians and surgeons that look like us? But I think it's worthwhile when you know that you're going to be taken care of.
So saying that kind of leads me into, what are some questions that you should be asking? I know when I go into the doctor, but I'm a pharmacist by training, so I go through and I have my list of questions. But for some people, they may not. So what should we really be asking when we go into the doctor?
I think it depends on where you're sitting. So you're 30 years old, no breast cancer, whatever. Say, when should I start my screenings? Based on my family history, what does genetic testing for me and my kids look like? What are signs that I should be worried about? What's considered an emergency? What's not considered an emergency? If you've been diagnosed with breast cancer and you're still in the throes of treatment, okay, what does surgery look like? If I decide I want to get reconstruction, how many surgeries do I have to deal with? Do I need chemo? What determines that? Do I need radiation? What determines that? Can this come back? There are so many things that people don't know and that doctors won't tell them. How often do I get my imaging, And then beyond that, okay, if I get arm swelling, do I need to go to physical therapy? Who do I go to? Start there. Some of them will look at you like you're crazy, like, who you been talking to? But start there.
Yeah, I think when you see your own advocacy happen in the room, they have no choice but to jump on. And we talk a lot about that, right? Like going in and having your own advocacy and really rooting for yourself. And can you tell me a little bit more about that? Like how can we continue to show up for ourselves in that room? And a lot of times in that room by ourselves. You're not with a caregiver. Sometimes it's us women going in and you're just by yourself, or you may have your kids with you. How do you continue to show up?
I always, even when it's my own doctor's appointment, I already think about what I want to get out of that visit before I even go. So whether it's the night before or the morning of, I'll write down my own questions. And I'm a doctor. It's so hard navigating the health system, so I can't imagine what the everyday woman or man goes through. But I encourage patients to be a part of that process. And so every single moment doesn't have to be filled with noise. I'll end and say, what questions, concerns do we have? And I'll sit there, give people a chance to talk and demand that out of your visits, but definitely going in prepared with your questions. And sometimes you don't know what to ask, but just doing your research, I think that empowers you to go in ready.
Absolutely.
And again, doctors and physicians and healthcare workers that look like you, I think there's a certain level of understanding when it comes to certain health issues that they can tap into. Okay.
I guess something else that we don't really talk about, and maybe this might entertain the audience a little bit, but about sexual history or sexual with having breast cancer. I saw a study earlier today about, that's something we just don't talk about, what happens with people who have breast cancer and,
They still want to have sex. That's what I think that sometimes the treatments can kind of determine what that looks like and what your sex drive looks like. For example, chemotherapy, you're tired and you're sleepy and you want to throw up. Who's thinking about sex when all of that is going on? I think about certain medications, such as some of the endocrine therapy that patients with hormone receptor positive cancers are put on, and they're going to be on anywhere from 5 to 10 years, and vaginal dryness, decreased libido, all these other things. And so I have a frank discussion with my patients, honestly. Like after they get through the treatment, I'm like, yes, celebration. So how are we celebrating? And how is life at home? How are things in your relationship? And they'll bring it up. But again, I think it takes somebody who actually cares and is going to ask the questions. And so we discuss different lubes you can use and different things you can use to make sex actually enjoyable after a breast cancer diagnosis. And I think so much of it is psychological, right? I mean, with chemo, for example, you're going to lose your hair. Depending on the kind of cancer, you get a mastectomy. And now, all of a sudden, you don't have nipples anymore. What if they aren't able to save your nipples? And that was an important part of your sexuality. It becomes a really big deal. And so having these discussions with your physician, and for me, I bring it up. There's ways around it, though. We can talk about that later.
Before we open it up to the audience, or anything else that you definitely think, well, let's do a true and false game really quick just to make sure you guys are awake and are hearing. A, the first one, how often should we get mammograms? Do men get breast cancer? Yes. How many, one out of blank, get breast cancer? Women, how many? Good. Y'all are doing so good today, right?
And no, your bra doesn't cause breast cancer. I just have to say it. Your bra does not cause breast cancer. Your deodorant, it's been hot. It's getting better, but put some deodorant on. It's not going to cause breast cancer. Yeah, that. I just had to say it.
Absolutely.
And cutting cancer and removing a cancer is not gonna make it spread. You not taking care of your health and leaving it there knowing you got something, that's gonna make it spread. So if you feel, I tell all my patients, if you feel something, say something. Get it checked out.
And if they don't hear you, tell somebody else. Well, if it's okay, can we open up to the floor?
Arizona, Colorado, Mississippi, Georgia, South Carolina. I'm missing one. Florida.
If you have a question, I'll give you the, hold on, let me go to, I'll be Vanna Black. Hi.
My question is, I'm Dr. Cherie, and I'm a 14-year breast cancer survivor.
Yes,
Whoop, whoop.
congratulations.
Actually, I found my own lesion 14 years ago today. So talk about a celebration to come out here and find out how to better take care of our health. But here's it's a question and it's a statement. I found out when I was diagnosed, I developed lymphedema. So while I got blessed and I'm a 14-year breast cancer survivor, I'm a lymphedema patient for the rest of my life. And so in my travels and speaking, I found too many breast cancer survivors that were not getting their lymphedema treated. They didn't even know what it was. Doctors and other people kept saying, it's just some swelling. Thank God you're a survivor. So I created the Live Today Foundation. It's a nonprofit 501c3 organization that educates physicians and healthcare practitioners on how to diagnose it, teaches patients about the importance of treatment, and we provide free compression garments to underserved and under-resourced cancer patients and survivors living with lymphedema.
That's amazing.
So here's my question to you, and I'm asking you to help me advocate. I am working with breast surgeons, medical oncologists, surgical oncologists, radiation oncologists, to have the conversation at the very beginning about the risk of lymphedema. Survivorship should be in your forethought, even when you get that diagnosis. That C word is awful and it's painful. But if I know my doctor is not only looking out for me now because he and she is assured that I will get the treatment that I need and will be a survivor on the other end, care about me on how I'm going to live out the quality of my survivorship when I'm done with treatment. Yes. So please, doctor, advocate with me and make sure you always have that conversation with your patients and let them know that 1 in 3 at-risk cancer patients will develop lymphedema. Absolutely. And it will, 75% of it is going to show up in the first 3 years. Absolutely. So let's add that onto our checklist. Can we do that, Mama?
I already do that.
Hey, that's what I'm talking about.
But yes, thank you. That's amazing.
All right, wait, well, before we're going to have a moderator say, ooh.
Ooh.
I mean, you guys don't really want to moderate. We have a special guest who's going to come up here and moderate the panel with these ladies. Too many credits. What's love got to do with it? Hawthorne, Shameless. Give it up for Vanessa Bell Calloway. Where's her music? Dun,
Hey Chris,
dun, dun, dun.
I'm so impressed you were trying to do some of my credits off your head. That means, see, this is like my baby brother, so that means he really knows me.
I know you.
Because he was just pulling it out the sky. I was like, okay, Chris, okay.
I know more.
Hello, ladies.
Hello.
How are you?
I was going to say, oh, drama, but you know. That's...
I love him. He was pulling it out the sky. Hello, everybody. Good afternoon. It's so great to see you all. And I apologize for being late, but we had a car service issue because I was supposed to be here to introduce these ladies because this is a special section for me because I am a 13-year breast cancer survivor.
Yes.
And And the doctor who I credit my success and my life to, Dr. Ronald Hurst, who's my personal physician, is back there. He's the head of Cedars-Sinai right now in the whole breast cancer department, and he's a bad mamma jamma, as we say. Thank you, Ron. I always like to call him out because, you know, ladies, when you do a journey like that, not only is your significant other and your family important, but your caregiver, your doctors that you basically are joined at the hip with are so important, because the relationship that you form with them, it lasts for years. Because I see him every year. I see him socially, but I just was in his office in August. So, you know, he's great, and it's so glad that any breast cancer survivors out here. I heard your testimony just a minute ago. Well, congratulations, sisters. We're breast cancer warriors. You've done more than survive. So we're going to take some questions, but I just want to, let me ask this other question. And I don't know if this question was asked, so I apologize if it has been. Has everybody here, all the women here, had your mammogram yet? So everybody has. Some hands didn't go up. That means you got an appointment and it's coming up. And all your friends, you're encouraging them to have their mammograms? And your daughters of age, you're encouraging them to have mammograms? Okay, because that's what saved my life, was early detection. I was stage 0 because I got my mammogram religiously every year. And this one particular year, I was a little couple of months behind, because the place that I normally got my mammogram had closed. It was 2009 when the whole economy got crazy. And I used to just run up there real quick, like, okay, I ain't got to make an appointment. They gonna just let me in real quick. I'm gonna just run up there. And I run up there and it was closed. I was like, oh, snap. Okay, I got to find another spot. And I got busy. In February, next thing I knew, it was June. But God woke me up one day and I said, something's wrong with me. And I woke my husband up and I said, honey, something's wrong with me. My husband's an anesthesiologist, and he says, well, what's wrong? You feel? I said, no, I feel fine. Because as you know, breast cancer has no symptoms unless you are really very, stage 4 or something, but stage 0, you don't know. I said, no, it was just something inside of me. I said, no, I feel fine, but I think something's wrong with me. And then I called my doctor, my general practitioner, and he said, well, what's wrong with you? I said, I feel fine. I just think you need to do a whole lot of blood work. And, I was very dramatic. I thought they were going to find some incurable blood disease or something, I was ready to be posted up like this, But it never occurred to me breast cancer, because I got my mammograms every year on time. So breast cancer was the last thing, but just something in my spirit told me that something was wrong. So I go to my doctor and he says, well, what was the last mammogram you had? I said, funny you should say that. I tell him the story about how I went in February and how they were closed, yada, yada, yada. He wrote a script right then. He said, I want you to go right across the street and get to the imaging center. I went, and I'll never forget, this was like a Thursday, Wednesday or Thursday, and that Friday, they called me back and said, we need you to come back in tomorrow, which was a Saturday, because we see some suspicious calcifications. And at that moment, I knew God had whispered to me, because that indeed was breast cancer. Not that I was being negative, I just knew that was what I felt. And when I went back that Saturday and I saw my imaging and I saw those, you remember, you ladies, how many of you have seen your breast exam, right? Interesting little exam, little picture, isn't it? So I'm looking at all the ducts in my breast and I see all these little white dots. And thank God they had not fallen out of my ducts yet, they hadn't fallen into the tissue. And when I saw those little calcifications, as they call them, I said, that's what God was telling me. That's going to be cancer. Because he kept saying, I don't know. I'm not a professional. I'm just did the imaging. I can't diagnose you. But he kept saying, but they look suspicious. They look suspicious. And that's when we took everything. I did a biopsy, and of course it came back that it was cancer. And that's when I took the pictures over to my friend Ron, and my journey began there. And ladies, and anybody, I'm gonna just make this one last testimony before we move on. There's a lot of different ways you could do your reconstruction. A lot of people, they want to do the implants. But if you ever can look into, or anybody that that will come to you trying to decide what kind of reconstruction they could have, I would recommend that they look into the flap. Does anybody know what I'm talking about? The flap? Did you guys discuss the flap?
No, we briefly touched on reconstruction. So with the flap, this is where they take your own tissue to reconstruct the breast. This is not implant-based.
Keep going.
Yes. Yes. So whether it comes from your back, that's the latissimus dorsi flap, whether it comes from your stomach.
And I didn't have a whole lot of fat, but just enough for a breast. Go on.
Whether it comes from your stomach, and so they're doing a deep flap, or it's falling out of favor, they're not doing it as much, but using your abdominal muscles to recreate the breast mound, that is an option. And so if somebody says we can't do that, like I told y'all before, somebody tells you what you can't do or whatever, or you're not getting a good vibe, you go find another doctor. But these are some of your options.
And even if you have to fight your insurance company, which believe it or not, I did for a minute, and I'm an actress. I'm like, yo, wait, ain't this why I got insurance? And I'm an actress, so I got to be careful about my look. But that, even not being an actress, it doesn't matter. If it's an option for you, and if you have insurance or you're willing to co-pay, whatever your situation is, you fight for what you want. Because the best advice I got, which was from a male oncologist who had breast cancer. When I was in, because what you do is these ladies, doctor will know, you kind of research the doctor you're going to live with for the rest of your life. And so you start interviewing doctors. And I interviewed this one oncologist, which was a man. I didn't go with him, but the best, and he said, I don't care if you go with me or not, but I want to tell you this. Make sure you use your own body tissue for your reconstruction if you can. And that was some of the best advice I got. And when I tell you I love that I had a flap, it is, and you take lemons, you make lemonade. You see, they take all that fat from your stomach, so you get a waistline back, I was 52 when I had my breast cancer, so my stomach been good ever since. Look good in dresses, child. And you can't even tell that this is a flap, girl. Come on, because this is my tissue. Come on now.
All right.
Quick clarification, because we talked about even after breast cancer, if you still have your breast, mammograms every single year. For those who do breast conservation and you decide you're going to do a lumpectomy, or you're able to do a lumpectomy and you save your breast, the breast that was affected, mammogram every 6 months for at least the first 2 to 3 years. That's something to be mindful of. That's number one. If you get a mastectomy, the breast tissue is gone. You don't get regular mammograms anymore after a mastectomy, with or without reconstruction. If we feel something, we start with an ultrasound, and then those patients will get an MRI if needed. Okay?
Yeah, I just get one breast mammogrammed every year, but I go every year. But just my left breast gets the mammogram. But anyway, I just wanted to share that with you guys. So we're going to open it up for some more questions for what? Oh, sit down. Sit your butt down, Vanessa. Okay. We're going to open up for questions.
I want to know if the fellas can flap. Because we need to get checked out too.
But y'all ain't got no real breasts unless you want
really
man
have real
boobs.
breasts. So
Yeah, all right.
You want man boobs?
Yeah, I
my
wanna
male
make sure.
patients, so
But yeah, because we're not going to the mammogram, so how do we get checked?
So yours starts with a physical exam, and for my patients, my male patients who do have a history of breast cancer, they usually end up with a mastectomy because of the fact they have very little tissue. But that other breast that remains, if they choose to keep it, it gets mammogrammed every year, because now you're high risk. And so after that diagnosis, mammogram every year on the non-affected side. My men, they ask about reconstruction too, because the same way a woman without her breast who doesn't get reconstruction, now they have the line from their incision, the men do too. And so a lot of my male patients ends up getting nipple areolar tattooing to make it look symmetrical with the non-affected breast.
A couple more quick questions.
After menopause, does your risk of breast cancer increase or decrease? A lot of that will also depend on the patient, and I'll tell you why, because our bodies are real tricky, right? So after menopause, the ovaries aren't responsible for estrogen and progesterone production anymore, but our fat is. So our body knows how to turn our fat cells into estrogen and progesterone, which is why postmenopausal women who need endocrine therapy get a different set of drugs than the premenopausal women. And so it goes without saying, the larger you are, the higher your BMI is, the higher your body fat content. That's more circulating estrogen that the body is able to create. So it kind of depends on the person. And then other factors like family history and genetics. If you have a genetic mutation, then that just trumps everything.
Hi, Dr. Pickford again. I had a client come to me one time. How do you address women who decide not to remove the lump, and even though it says it's negative, but in actuality, it still may be positive?
My question, and again, I'm not giving out medical advice, nor am I speaking for other physicians, but anytime somebody has a biopsy, I look for certain things. In addition to having a discussion with the pathologist, I want to talk to the radiologist because they'll see those results. And we want to know, is it concordant or not? So even though the biopsy may be negative, how bad does the imaging look? You know? And so that's something I pay attention to because biopsies are subject to mistakes as well, depending on where the needle went or assuming the person even went in the right place. And so when I don't know, I just get additional imaging to build up my case. So I might get an MRI, I might get a PET scan to, you know.
Yes.
Last question.
Last question.
Yes, I want to thank you three queens on the panel today. My question is real briefly, is there a relation or correlation with all of the vaccines that we have taken lately?
No.
Thank you so much. Thank you. Thank you.